Hey everyone, good morning. Let me know if you can hear me. Getting. Oh, perfect. We'll get started in just a few minutes here. 8 o'clock hits. If you have any questions, go and post them up. Hey, Sadie. You guys for joining me this early Friday morning. You guys are ready to start your weekend in pharmacology. Hey there, everyone. 22 in so far. It's 8 o'clock, so I'm going to get started. All right, well, welcome back. I think we left off on beta blockers, but if that's not correct, let me know. So I graded your prescription assignments. You still have 2 weeks before the next one's due, so that's plenty of time to take that feedback into account. Couple things to note when doing your assignments, at least some of the trends that I noted. For one, make sure you include your credentials down in the signature portion. The reason why that is because sometimes on your prescriptions, wherever you're working, you may have like multiple names up at the top. And so if you don't include your credentials at the bottom and it's just your signature, it can be difficult to tell like who was even signing it in the first place. So that can be handy. So at least if I'm like calling back to see, what's going on with a particular prescription, I can at least ask, oh, the content is emptying canvas for the assignment. Oh, did I not post that up? Check that. Oh, that's strange. Okay, let me fix that. I apologize for that. I'll take a look at that and give you guys an announcement. But at least I can still refer back to the assignment. Yeah, we should have known that beforehand. Thought that was already up. Anywho, but you guys will have 2 weeks to work on it. I'll make sure I'll adjust the dates to make sure you at least have that. So, anyway, point being is you at least want to include your signature. So if you don't do that in the future, we'll start counting off. So just FYI. Other things to also think about include like when you're writing your instructions, it's good that you want to include a lot of extra information, like make sure not to take this medication within 2 hours of this, or make sure if you have signs of anaphylaxis, do that. Like that's all well and good, but on a prescription bottle, you have very limited space you're working with, and so it really should be relegated to just saying to the patient how much to take, when to take it, how often, all that sort of thing. So if you try to include too much on there, it's going to get very crowded. You may not have room for it all. And so you just really want to include the basics there. The other point, though, is that when you're educating the patients on this stuff, that's when you're going to tell them that. So you're going to tell them, hey, make sure you don't take this at the same time as milk. Make sure if you notice any like wheezing or rash or anything, make sure you go ahead and, call the ER, whatever the case may be. So you don't want to crowd out your prescription because there's too much information there. Other things to double check to make sure that when you're writing it that it's an available concentration and that the size of the product is consistent. So for instance, for things like creams where we can't really separate those out, it's always going to be like just the whole tube that they're getting. Make sure that it's one that's actually available. So if you say like a 0.1% product and you say I only want to use 15 grams, well, it probably doesn't come in that size. And then I'm not going to give them a partial tube, so it really doesn't make sense there. So you want to make sure and double check on that. Most people are pretty good on that, so it wasn't too big of an issue. And then for liquids, for the most part with liquids, just assume that we're going to give them the exact amount and then just put how much they actually need. For antibiotics, I let it slide this time because typically we give them the whole bottle anyway, because those are typically short dated after we reconstitute them. But for a lot of other things in the future, for future assignments, you're going to find that we will only give them what they need, right? We'll actually separate out from a big bottle, put it into a little bottle. And so just write out what they need and you're fine there. If you write a few extra mLs, that's fine, but just make sure you write out specifically what they need, okay? So anyway, otherwise it was a good job on that. You guys did. Actually, the average I think was quite high, so I didn't have to count off on much. So anywho, so I'll get that second one posted up here. You'll have 2 weeks roughly to work on it, so I think that'll be plenty of time to take your feedback and then act on that for the next one here. But let's continue on with our talk of medications for hypertension. We were talking about calcium channel blockers, talked about ACE inhibitors and all of that. Now we're moving into the beta blockers, and so these do exactly what they say. They simply block the beta receptors, right? And so we have two primary ones we'll talk about. There's beta 1 and beta 2. We have talked about asthma already, so you guys have a pretty good idea of what beta 2 does. So beta 2 being the primary sort of like smooth muscle relaxant in terms of its action. So for instance, like, in this bronchial smooth muscle, you activate beta 2, you're going to end up seeing relaxation of that smooth muscle. You can see the same thing on the blood vessels too. It actually causes vasorelaxation to a degree. And so that'll be important for some of these actions here in just a little bit. But for the main one here, we're talking about beta 1. That's going to be mainly found on the heart. And if you stimulate that with things like epinephrine and norepi, you're going to cause increased heart rate, contractility. So by blocking that, you're going to slow down the heart rate and you're going to decrease the contractility. Okay. There's some other actions too we're going to see. So for instance, by blocking beta 1 receptors, you can actually decrease renin release coming from the kidneys, which can be important because you decrease that, you decrease angiotensin II production. And you can also see some other actions on places like the liver, the skeletal muscle, all of those things we'll get into. So if you have a good understanding of what beta receptors do in the body normally, you'll have a good idea of what happens in terms of both therapeutic effects and toxic effects when you block those receptors here. So other things we'll see is that beta blockers can overall reduce activity of the sympathetic nervous system, because if we block presynaptic beta 2 receptors, that actually helps to decrease norepi release, and norepi is a vasoconstrictor, so if you decrease that, that can help out with the blood pressure. And then we're going to see from a CNS perspective, along with that sympathetic nervous system activity being diminished, we can also see that has effects on things like migraines. We can see some effects on mental status. And then also the baroreceptors are affected by this as well, right? Baroreceptors being receptors that respond to pressure. And so this is going to be a primary thing that gets altered in patients with hypertension, because over time, your body might be used to a 120/80 in terms of blood pressure, and your baroreceptors will respond to that if you go outside of that. So for instance, if you have low pressure, it's going to respond by doing things to get that pressure back up, by either constricting the blood vessels or trying to hold on to more blood volume or something like that. If the pressure's too high, it's going to try to get rid of that. Well, with patients with hypertension, they're chronically high, right? So if they're chronically sitting at 150/90, for instance, then that's what their new normal is. And so if you try to change that, the baroreceptors don't like it. And they say, well, we want to get that pressure back up to normal. So one of the key things we're going to try to do for these patients over the long haul is to get their baroreceptors sort of reset back down to what we would more consider normal, close to 120/80, right? The beta blockers can help out with kind of all of these things here. So the differences in beta blockers that we're going to see have to do with things like selectivity. So do they block both beta 1 and beta 2 receptors equally, or do they have a preference and maybe they only block beta 1 preferentially? We'll look at that. Some other factors that go into it include things like their metabolism. Some of them are going to be more renally eliminated. Some of them go through the liver. That can have an effect on things like the half-life of the drug, how easily it's able to be cleared. Obviously, if patients who have renal dysfunction, if they're not able to clear the beta blocker very well, then they're going to have it sticking around for longer, and it's going to cause more issues in terms of them having higher levels and having more toxicity potentially. And there's some other ancillary sort of things here. So for instance, some of them have what we call an intrinsic sympathomimetic activity. This is something that doesn't come into clinical consideration a whole lot, but you can see where they can have some partial agonist activity at certain beta receptors, and they may have some activity for things like asthma and heart failure and whatnot. I'll probably not talk too much about that. That's something you may hear about beta blockers. Other things include this feature called membrane stabilizing activity. That's going to be something we'll mention more in the antiarrhythmic section after it'll be in the last section of the class, but it has to do with its ability to stabilize the myocardium and prevent arrhythmia from occurring there. So we'll mention that a little bit later on. And then the issues we'll see with third generation beta blockers. So I'll talk about the delineations and generations in just a few minutes. Their third generation agents, they also have some additional activity that help them out with things like blood pressure management. So things like nitric oxide production, which we're going to get a lot into the nitrates today. Things like alpha-1 antagonism. So normally alpha-1 causes constriction of the blood vessels. So if I block that, we're going to cause relaxation of the blood vessels. Beta-2 agonism, antioxidant activity, all kinds of additional side benefits we'll see with the third gen beta blockers. So here are the first gen beta blockers. We're going to consider these to be the non-selective beta blockers, meaning they affect both beta 1 and beta 2 equally. A handy mnemonic that I use for remembering which ones are which in terms of generation. If a beta blocker begins with a letter N as in Nancy through Z, you can typically consider it to be a first gen non-selective beta blocker. So things like Nadolol, Penbutolol, Pendolol, because it's easy to identify a beta blocker because they all end with lol at the end, LOL, right? Not a laughing matter by any means. But you can see here that by delineating them in their generation, that's going to be really important for like testing purposes and for treating your patients down the line there. So while easy to identify a beta blocker, getting the actual generation down may be a little bit more of a challenge. So again, N through Z, that's how I think about my non-selective first-gen beta blockers, okay? So on this slide here, you can see with the drugs underneath the name, if it has like RE, that just stands for renal elimination, and for HN, that stands for hepatic metabolism. That's more for your information. I'm not going to get super granular on the exam and ask you which ones are renal versus hepatic. Similarly, I'm not going to ask so much about membrane stabilizing or the intrinsic sympathomimetic activity. This is more for your information. However, I will ask about things like lipid solubility because this can affect some of the side effects that we're going to see later on. So kind of keep this in mind. Things that have higher lipid solubility have an easier time getting into the brain, and that can cause some certain side effects or therapeutic effects, as we'll see in just a little bit. So things like propranolol or Inderol is a brand name, has high lipid solubility. So there's going to be certain patients you may want to use this drug in, and certain patients you don't, depending on the clinical situation, right? So those are the first generation beta blockers. Next, we're going to have our second gen, or what we call the selective beta blockers, right? And so they are selective for beta 1 receptors, meaning they hold off and they don't affect beta 2 receptors very much at all. Okay. Now, selectivity with any drug is going to be relative. So, for instance, if you have a high enough dose of a drug, you can overcome that selectivity and affect both types of receptors. So it's not an all or none sort of phenomenon, but when using therapeutically, these are going to be preferentially affecting beta 1 receptors. So this is going to make these better options for certain types of patients. And this is sort of the crux of what's going to be on these test questions, and again, when you're treating patients, is trying to select which drug is the best for your particular patient. So if you're treating someone with asthma, for instance, you're going to see that affects your drug selection differently than if you're treating someone who has hypertension with diabetes. So we'll get into some of those finer points here in a few minutes. But how do you tell a second generation drug? Well, in general, if it starts with the letters A through M, then I can generally be assured that they're going to be a selective or second generation beta blocker. So things like acebutolol, atenolol, bisoprolol, esmolol, and then metoprolol. Esmolol, I put IV there because that's kind of a primary way you're going to see that being given. It's a very short-acting beta blocker, and that's why we call it Breviblock, so kind of short block. I can kind of talk about that later. Notice here generally low lipid solubility, so CNS effects are going to be sort of kept to a minimum for the set of drugs here. Now, I talked about the naming conventions as being useful there. They kind of fall apart with the third generation drugs, so you just kind of have to know which ones are third gen by looking at them, so because they don't follow the A through M sort of convention here. But we have things like cardiolol, carvedilol, labetalol, and then betaxolol. We talked about a few of these already when we were mentioning them in terms of ophthalmology. We talked about glaucoma. The two big ones here we're going to be seeing most likely from a systemic standpoint is going to be carvedilol and then labetalol. And so you can see here they have some additional activity. So for instance, they can block alpha-1 receptors. So that helps out with vasorelaxing properties, and that helps out with the blood pressure management, right? Things like beta-2 agonism with labetalol. That's handy because if you activate beta-2 receptors on the blood vessels, that causes smooth muscle relaxation, just like it does in the lungs. And that can help out with the blood pressure as well. So really depends on sort of what you're looking for, and we'll talk about different clinical situations where one of these may be better than the other. So we'll kind of get into that. And you've probably seen some of them being used clinically before. You may have wondered, like, well, why do I use this one versus another? And there's probably a good reason behind that, which we can talk about. So what are the clinical indications for beta blockers? Well, hypertension can be one of them. You're going to see that beta blockers are not used first line, though, because of the fact that there are significant side effects to the drugs. The body is going to be somewhat resistant to their effects in terms of blood pressure management. So these are good add-on drugs, and these are especially handy in patients who have other comorbidities that sort of require use of a beta blocker, and I'll talk about those in just a little bit. Now, they tend to work good in young patients. However, they're going to have some issues to where they're going to be pretty intolerable by young patients because they limit exercise tolerance, right? And so that kind of makes sense when you think about it. If you're a relatively young person, just with hypertension, and you're trying to get up and move around, maybe go run a 5K or something like that, you're going to find that the heart is not able to sort of keep up with the oxygen demand by the rest of the body, because it can't increase the heart rate enough or the cardiac output enough to keep up with it, right? Because those beta receptors are being blocked. So by preventing the muscles from being supplied with oxygen, then you're going to get tired out too quickly, and then you can't really run that 5K like you normally could. So that's why frequently young patients don't like it, because it sort of limits their exercise tolerance, right? So not great, but we're going to see actually some cases where beta blockers can improve exercise tolerance for different types of patients, as we'll see there. So they're still used pretty commonly in elderly patients, basically based off of their comorbidities, but we'll look at that in a little later. So, and you can see here sort of the kind of what I'm getting at in terms of why we don't use beta blockers for their initially for blood pressure management, because in the initial term, if you're looking at this slide here, we have mean arterial pressure, we have cardiac output, and then total peripheral resistance. You're going to find here that acutely, these are not going to be awesome for managing the blood pressure because of the fact that we have these compensatory mechanisms, right? So for instance, here when you're looking at using a beta blocker initially, so don't worry about the ISA portion here, but let's say for cardiac output, what happens if you add on a beta blocker in the acute term? Well, you're going to see a decrease in cardiac output, right? Because you're blocking the beta receptors, you're slowing down heart rate, and you are decreasing contractility. So, you know, those are the two things that make up your cardiac output: stroke volume and your heart rate. So by decreasing that, I get an acute decrease in cardiac output. However, the body doesn't like those sorts of changes. So what does it do in response to decreased cardiac output? Well, it's going to bump up the total peripheral resistance. This is kind of the opposite of what we saw with the dihydropyridines like amlodipine, where with those you saw an acute decrease in TPR, but then you had a bump up in your cardiac output, which is why they cause reflex tachycardia so frequently, right? So this is the opposite effect here, where by decreasing heart activity, we're going to be increasing the blood pressure squeeze essentially or trying to increase the squeeze on the blood vessels. So that way we see very minimal changes in terms of our MAP, right? MAP is going to stay roughly the same here. So that's the acute phase. Overall, long term, what we're going to be finding is that with beta blockers, we can help with things like the altered baroreceptor responses. So they actually go back closer to normal. We're going to have less renin release, which makes less Ang2. We're going to have less norepinephrine release. And so chronically, we can see that these are handy for managing the blood pressure. MAP ultimately goes down because cardiac output is still diminished here, but we're going to see that the total peripheral resistance is going to be starting to kind of go back down because of these other ancillary sort of effects here. Okay, so good as an add-on drug for hypertension, not great as a first-line drug typically. As I mentioned, glaucoma we've seen used previously, so I'm not going to harp on that. And then in some cases, we can actually use it for migraine prophylaxis. So typically, we're going to see drugs more lipid soluble are going to be used here. So things like propranolol most often, but others can be used as well. And basically, it has to do with sort of the managing the blood vessel activity up in the CNS. So whether you're having a lot of vasospasm or whether you're having a lot of vasodilation. Actually, in and of itself, beta blockers can cause migraines to occur, but for prophylaxis purposes, they can actually help out. And so we will talk about this more extensively in the neuro section next semester. So don't get too worried about that at this point. Hyperthyroidism is another indication you may see occasionally. This is kind of a handy feature because if you think about someone who is hyperthyroid, they're having increased metabolism, they're hypertensive, they're tachycardic, they're sweating, they're anxious. This helps to decrease a lot of those symptoms by blocking beta receptors. So it helps to bring the heart rate down, helps out with blocking beta receptors in the skeletal muscle so they're not as tremulous, helps out with anxiety. And so we're going to see here that while it doesn't necessarily fix the blood pressure associated with thyrotoxicosis, another additional benefit we're going to see is that it helps to block peripheral conversion of T4 to T3. And so if you know anything about thyroid hormone, it's that T3 is a more active form. So if you have less of it being formed, then that's going to help out overall. We'll talk more about that when we get into the endocrine section next semester as well. We're going to talk about angina extensively coming up in the next slide set here. But basically, what is angina? Well, it's symptoms of ischemia, right? Our oxygen demand in the heart is too high and our supply is too low. So by having this imbalance, you cause ischemia, and that causes the chest to start hurting, right? And so what we're going to see here is with beta blockers, we can actually help to decrease overall demand on the heart of oxygen by decreasing cardiac output and decreasing heart rate and contractility and all of that. And so for those patients, you can actually improve exercise tolerance because it takes them longer. They can have longer bouts of activity before they start to have anginal symptoms. We'll talk more about that in just a little bit later when we get into the next slide set. Other things we're going to be using here include acute myocardial infarction. This is actually going to be one of those meds you have to put patients on after MI because they actually help to prevent recurrent MI, and they actually help to improve mortality for these patients here. We're going to talk extensively about that in just a little bit. And we can also use these for supraventricular arrhythmias. These can kind of be used similar to how we use non-dihydropyridines like verapamil and diltiazem because they help out with AV nodal conduction slowing, and they're useful for supraventricular arrhythmia. So things like atrial fibrillation, PSVT, things like that, they can help to slow down and keep the ventricles pumping at sort of a normal, efficient rate. So other things we can see, we can actually use these for panic attacks. And this is interesting from both the sympathetic nervous system effects and then also from the CNS or central nervous system effects. If you imagine someone who is having a panic attack, say for instance, you have to give a speech, right? You're having performance anxiety or something like that. They're all kind of mediated through the same features, right? Through the sympathetic nervous system and whatnot. So by giving a beta blocker, it helps to reduce down like the tremor patients may develop. It'll help to reduce the rapid heart rate they're experiencing, the blood pressure effects, sweating, all of that. So even though a person may feel nervous, they will not demonstrate the physical features of that, or at least they'll be diminished here. So you may find a lot of people will use beta blockers before they give a public speech, for instance. because it's going to be able to help out with kind of both features there. And then for tremors, sometimes you'll see them used as well. CHF is another important one, and again, what often begets CHF? Well, typically myocardial infarction, so it makes sense patients with a history of MI are probably going to have issues of CHF down the road, because what is CHF but left ventricular dysfunction in a lot of cases? Oftentimes RV dysfunction is going to go along with that as well. Depends on what the kind of underlying pathophysiology is. But what we find is that with patients with CHF who have poor LV dysfunction, you know, they have an issue of not being able to pump very efficiently out of the heart. The ejection fraction is reduced because either the afterload is so high because they're having to pump so hard against that, and the ventricles become stiffer and hypertrophic and all of that. So by giving a beta blocker, you kind of help take some of the pressure off the heart a little bit in terms of workload. You help it to pump more efficiently, and so you actually find that with certain beta blockers, things like carvedilol, metoprolol succinate, and bisoprolol, you can actually end up improving mortality and morbidity for these patients. I'll talk more extensively about that in an upcoming cardio section, but just know these are these three in particular are good for CHF. Now, normally I don't harp a lot on the salt forms of medications because typically it doesn't really matter for our purposes. But here, notice I'm talking about metoprolol succinate. There's two varieties of metoprolol: metoprolol tartrate and then metoprolol succinate. Tartrate is the immediate acting form. That is not the one you want to use for CHF. Metoprolol succinate is the long acting form, and that's one you want to use. So for instance, with like a metoprolol tartrate, you may see it used Q12 hours. Here, metoprolol succinate is used Q24 hours, right? How do you remember that? Well, I think about hard candy, right? I think about things like, I don't know, maybe if you're a grandpa, Werther's Original, Everlasting Gobstopper, or something like that. Something that you can suck on for a long period of time that lasts a while. Think about succinate, right? Because that hard candy is lasting while you're sucking on it for a while. So I think metoprolol succinate, I think it's lasting for a long time too. And so that's how I make that differentiation. If that doesn't work for you, however you want to remember it, I do not care. That is up to you. But again, some of this stuff seems counterintuitive because initially if I gave someone a beta blocker with CHF, you can cause an acute decrease in their LV dysfunction because their contractility is going to go down. And so you can put them in a decompensation, end them up in the hospital very easily. So you have to go really kind of, you have to start low and go slow with those kind of patients there, because again, there's no rush necessary to get them on that, but it could take weeks before you really get them up to a therapeutic dose. So again, very important indication to remember, but you have to be really careful about how you're using it, because it's very easy to go kind of too fast with them and then put them back in the hospital. So next up is, you know, some of the adverse effects we're going to see with beta blockers. So bronchoconstriction is a risk with these. If you have someone with COPD, if you have someone who has reactive airway disease, asthma, you want to be cautious here, because if I use a non-selective beta blocker, I'm going to be blocking up those beta-2 receptors, which can either induce an asthmatic response, or if I'm using something like albuterol to reverse that, it may be less effective, right? Because the receptors are occupied, being blocked. So you want to be careful there. In those cases, you can utilize a beta-1 selective drug. Does that mean that every asthmatic patient is going to have a good response to a beta-1 selective drug? Not necessarily, but it's safer. So in general, you're going to have an easier time using a beta-1 selective drug like metoprolol for an asthmatic patient over something like propranolol, for instance. Okay. Now, be aware of the cardiac depressive effects here, right? So for patients who have acute, decompensations of CHF, they don't need a beta blocker, because you're going to decrease that cardiac output even further, and that's exactly what they don't need at that point. Also consider their heart rate. If they have AV block, or if they're in Brady or sinus bradycardia, that's going to worsen that further, right? And so again, talking about heart rates usually less than 60. So if they're less than 60, you don't want to add on any more heart beta blocker, because that can just worsen that. Okay. So again, the contraindications are important to know there. Now, you can also see some issues with glucose for these patients, and it kind of can depend on whether you're dealing with like a type 1 or type 2 diabetic patient. Remember that beta 1 receptors and beta 2 receptors are going to be important for causing certain effects both on the pancreas and in the liver. Remember, if you're in a fight or flight response where you're releasing a lot of norepinephrine that would normally activate those receptors, what do you need? Well, in order to run away from a a threat, you need glucose to supply to the muscles there. So that means I need to be producing glucose in the liver, gluconeogenesis, and I also need to produce less insulin, because insulin's not necessarily going to help me in that point in terms of blood sugar. So what you tend to find is by blocking beta receptors, you can actually end up seeing some issues in terms of insulin homeostasis issues, along with glucose production in the liver here. So what happens? Like, well, imagine if you have a type 1 diabetic patient who is someone who can't produce their own insulin because of, say, like an autoimmune reaction. Well, in those cases there, you're preventing the liver from producing as much glucose as it normally would, because there's less activity of things like norepi and epi on the liver itself. And so by blocking that glycogenolysis, you can cause them to become hypoglycemic. Okay, not great, because again, that can be deadly because your brain needs glucose. Not only that, but it can also mask the symptoms of hypoglycemia, right? So I don't know if anyone's ever been hypoglycemic before, but it's like being really hangry, where you get kind of like shaky and you get sweaty and you have palpitations. You mask a lot of those symptoms when you have a beta blocker on board, just like we saw with use for a panic attack, for instance. So again, these patients can be low in terms of blood sugar, but not realize it until almost it's too late and they have a syncopal episode, for instance, right? Not great. From a type 2 diabetic patient standpoint, where their issue is not so much they can't produce insulin anymore, but more so that they're resistant to insulin and they can't control their blood sugars, hyperglycemia is going to be more likely to be seen, because we're getting less insulin being produced because you're blocking beta receptors on the actual pancreas. So you end up ultimately seeing more glucose out in the bloodstream, which they already had a problem with in the first place, and so that makes it difficult to control their blood sugars. So also, not only that, but if they do get low, so say for instance one of these patients are taking insulin themselves, or they're taking like a drug that produces more insulin, like a sulfonylurea, that can also mask the symptoms of hypoglycemia. So a very important counseling point there, to make sure that they're checking their blood sugar regularly, and make sure that they are more cognizant of other signs and symptoms of hypoglycemia. That way they can correct that if need be. So other patients who may have issues with beta blockers include if they have like peripheral vascular disease and things like that, because you can impair peripheral circulation further with beta blockers. So for instance, with patients with PVD or PAD, if they have intermittent claudication, this can worsen that to a degree. If they have Raynaud's phenomenon, that can actually worsen that as well. Someone's asking, so are beta blockers contraindicated in diabetics? No, they actually are not, because what do diabetics also frequently have? A lot of times they have issues of MI, or they have issues of CHF, and so this is going to be a compelling indication. You just want to be cautious with those patients, right, and make sure you're looking at their blood sugars more closely. So certainly not contraindicated, and frequently they're going to have a compelling comorbidity that requires a beta blocker, okay? Again, for some of these conditions, you're going to find that places like Medicare and Medicaid, they're going to require certain meds to be on board. Otherwise, that can affect your reimbursement, right? So that's, and again, that may not matter to you so much if you're working like in a bigger healthcare system, but when your evaluators come back and they say, hey, we didn't get paid for this patient because you forgot to put them on a beta blocker, that can affect your livelihood, right? So again, these are things you have to do because we know that they are going to be beneficial for the patient in the long term. And of course, that affects the money aspect of things, because the insurance company does not want to pay for a patient to come back for a recurrent MI because you forgot to put them on a beta blocker, right? So again, it kind of all goes back into making good use of our resources, and also making sure that we're getting paid, because if you don't get paid, then you don't have a job, unfortunately. Other things we're going to see here with beta blockers too is we can have what we call a sudden withdrawal syndrome. So this is a class of drugs you do not want to discontinue abruptly in your patients, okay? What does that mean? Well, overall, when you're taking beta blockers in the long term, by blocking those receptors chronically, your body's going to say, well, I don't have enough beta activity going on here, so let me try to make myself more sensitive to it by upregulating beta receptors that are available, okay? So you have an upregulation here. You have more beta receptors in the heart and in the vasculature and everywhere else. And so when you remove that all of a sudden, so say for instance a patient goes on vacation and they forget all their meds, all of a sudden when those beta blockers clear out of the system, they are now much more sensitive to the activity of things like norepi and epinephrine. So what does that mean? Well, you can see acute rises in blood pressure because of that. You can see acute jumps in myocardial oxygen demand, which can induce angina or MI, and patients have died from this. So if you do have a patient who you need to take off a beta blocker and they've been on it for a while, so say months to years, they need to slowly withdraw off of this, right? So slowly reduce the dose over time. May take weeks, may take months in some cases. Just depends on how sensitive they are from a cardiovascular standpoint in order to mitigate this, okay? So again, you could have a classic, situation. Patient forgets their meds, goes out of the country, for instance, has no access to it. All of a sudden, wakes up, chest pain, related to this hypersensitivity they have there. Other things too, you want to be careful in patients, especially elderly patients. You want to avoid using highly lipid soluble agents for them because it tends to cause worsening depression. You can see things like hallucinations and nightmares are frequently reported. And you may see that is also associated with a lot of fatigue, right? And so again, you have to think about, especially with elderly patients, and they're starting to act a little altered from their mental status standpoint, is what's going on here. Is it due to infection? Is it due to the fact that they're taken out of their normal environment? Maybe now they're sundowning in the hospital. Or is it the medications we supplied them, right? Always want to look back at the meds because that is a frequent cause for altered mental status in elderly patients, and it's a very easier thing to treat than some of the other stuff. So for instance, if I give them a med that made them act extra loopy, or they're acting aggressive, or they're having hallucinations, you can probably take away that med and try something else, right? As opposed to trying to manage those symptoms with more medications, that's going to make them also even more altered. So you want to be careful there. We'll talk much more about the elderly next semester. And then there could be some issues with the triglycerides, so you want to monitor the lipids as well. So what are some drug interactions? A lot of these are going to be from a pharmacodynamic sort of standpoint. So for instance, you don't want to put a beta blocker with a non-DHP because they can have synergistic effects to reduce blood pressure and heart rate. The contractility is going to be going down, so you very rarely ever use those two together, right? Some other drugs we'll talk about, including things like Clonidine, again, will have synergistic abilities to reduce heart rate and blood pressure. So typically you don't want to use two cardioactive or two cardiodepressants at the same time because, again, that can lead to severe bradycardia, and that decrease in cardiac output can lead to hypotension, right? So I think one of the last classes here we'll talk about are going to be what we call the central sympatholytics. Now, what's a sympatholytic? So, sympath, you think sympathetic nervous system, you think lytic, you think lyse, you think stop, basically. So a central sympatholytic means centrally it's working in the brain to decrease the activity of the sympathetic nervous system, okay? So this is going to shut down release of things like norepi from those sympathetic nerve terminals to overall have a decrease in things like blood pressure and heart rate, okay? They do this by activating these alpha-2 receptors, and also there's some of these what we call imidazoline receptors here, right? By activating these receptors, they actually cause a decrease in the activity of the sympathetic nervous system overall, okay? So they work in various portions of the brain here, so I don't really care which portions specifically, just know they're working centrally, right? They're a central sympatholytic here. But overall, by activating the receptors here in places like the medulla and the solitary tract here, you can end up finding that they will have overall decreased activity. And so that also makes sense why they can cause effects on mental status as well, right? It's not just that slowing down heart rate and blood pressure, also slow down the brain overall as well. You can kind of see here how this can affect it. So clonidine is sort of like the classical agent in this group of drugs here. You can see how it can have positive effects on the vagus nerve, right? So that way you can actually end up seeing decreases in heart rate here or decrease in cardiac output. More importantly, though, on the sympathetic ganglia, these are going to be inhibited downstream. So that way you end up seeing less norepinephrine being released, which means less norepi effects on beta receptors in the heart and less norepi effects on alpha receptors in the blood vessels. So overall, decrease in blood pressure, decrease in heart rate, which may be beneficial for some patients, right? So general effects, you're going to see decrease in total peripheral resistance, heart rate, and cardiac output are going to be diminished here, okay? So some advantage you can see with this is that, one, you get a pretty good decrease in your blood pressure with only kind of a modest decrease in cardiac output, probably less so than you would see with something like a beta blocker. And it kind of works for all ages, all genders, all races, because again, it's working centrally in that sympathetic nervous system. And for most people, it's all the same. It doesn't really matter whether their race is different or age or anything like that. For some patients, it's good for monotherapy, but we're going to see there's some drawbacks, and mainly from the from the central nervous system effects we're going to see here, that may make it unideal or not ideal for some patients. We're going to see that, but overall, pretty good set of drugs. The downsides I was mentioning there are going to be things like the drowsiness and sedation, right? So basically, it's kind of shutting off the sympathetic nervous system in your brain as well, and it's going to kind of slow things down a little bit. You're going to be less aroused in terms of your attention. You're going to be more drowsy, all of that. You're also going to see frequently sexual dysfunctions associated with this, and they have a relatively narrow therapeutic range, so even small increases in dose can see some big side effect changes, as we'll see in just a moment. They also suffer from an abrupt withdrawal hypertension as well. Just like with beta blockers, this can do the same thing. So you have to be really careful and slowly titrate patients off of this. Otherwise, you can induce things like severe hypertension, MI, all of that. So a couple of drugs in this category, including things like Clonidine. This is, again, an alpha-2 agonist, also activating some of those imidazoline receptors there. And this is kind of the classic central sympatholytic you probably think about most frequently, or most people will think about. Again, decreasing sympathetic nervous system activity, a little bit of increase in parasympathetic. So you see that increased tone of the vagus nerve on the heart. And you can see some increase in blood glucose. So again, you do want to be careful there in those diabetic patients. Other effects we're going to see as well includes decreased ADH secretions that can help out with water balance and getting rid of some water volume there. But as a result of that, as a result of decreased effects on the, or a decrease in blood pressure, that will cause the patient to go into more of a sodium retentive state, right? So the kidneys are going to detect there's lower pressure, so they're going to want to hold on to more salt and more water, so that increases renin release. So we oftentimes will give this with a diuretic to help prevent that. So maybe putting this with a thiazide, for instance, can help to offset some of those effects there and keep the blood pressure low in these cases here. But dry mouth, sedation, these are going to be common side effects you're going to see there, which may be okay, right? For some patients, sedation with these drugs may be fine, especially for things that we can also use them for, like analgesia. So if you ever, if you're working like in ortho, for instance, or in surgery, you may see patients on the post-op setting be put on epidural infusions of opioids. We also will sometimes add this along with Clonidine because it actually has some good analgesic properties in the spinal column, and it helps us to reduce the overall opioids that we need for those patients there. Not only that, but actually blunts withdrawal reactions we get from opioids, which we'll talk about next semester. But we use this all the time for patients who have what they call neonatal abstinence syndrome. So for instance, if you have like a neonate who's born and their mom was using opioids throughout the pregnancy, we can find that they have a really hard time with that because they have now lost their source of opioids, and so they're withdrawing just like any patient would. And so Clonidine can actually be used for them as well to help kind of blunt that response to some degree. So as I mentioned, the withdrawal reactions are very important to be careful with there. You want to make sure you are slowly reducing the dose over time to avoid those withdrawal reactions there. And you can also see issues with orthostatic hypotension, which can be especially problematic in elderly patients, because what happens when you stand up and you have hypotension, well, you get kind of dizzy, more likely to fall and then have a fracture. So be careful there. Certainly sexual dysfunction, bradycardia, all those things would be expected. Ellie's asking, could Clonidine cause kidney stones? Not that I'm aware of. Not that I know of. I don't think I've ever seen any instances of that, but if there's a sort of interaction there or something else that I'm not thinking about, certainly let me know. But yeah, I don't normally think about that. Other drugs affected this category as well include guanfacine or 10x. This is a little less potent, and so you see less sedation with it, less efficacy overall, and also less withdrawal reactions. So you can kind of think about this as a weaker version of Clonidine that can be used for some patients. And again, these can also be add-on drugs, right? You could have a patient who's on, a thiazide diuretic, maybe a calcium channel blocker, and you can add this on additionally, potentially. So just something to think about. And then sometimes you need 3 or 4 drugs just to manage these patients here. Okay. A few other ancillary drugs we'll mention here include one called Hydralazine. This is going to be a direct vasodilator, so kind of switching gears from a central sympatholytic to something that just works directly on the blood vessels. This one here has several actions here that help to reduce blood pressure. Probably has to do with some increased nitric oxide production. Probably has to do with calcium effects or whatever, but basically it's directly relaxing the blood vessels to decrease blood pressure. So one thing to note with this one is that it undergoes metabolism through this acetylation pathway, okay? Now the acetylation, you're going to find that some patients are going to be fast acetylators and some people are slow acetylators, okay? Slow acetylators are going to have a harder time getting rid of this drug. So levels are going to build up and you're going to be more likely to see some of the side effects you're going to see here in just a moment. Fast acetylators are going to get rid of the drug too quickly and they may see diminished actions here. So these drugs may not work well for patients who have a fast metabolism. They're fast acetylators. Can you look at a patient and tell if they're a fast or slow acetylator? No, right? Frequently, you just have to try it out and see how it works. We don't have reliable tests that we do frequently in order to see how which their metabolism state is. Now, again, something like this is a direct vasodilator is not good by itself because the body resists change like that. And it's going to see a big increase in renin release, angiotensin 2. You're going to see a lot of fluid retention, big increases in cardiac output. So just like with amlodipine or DHP, by dilating those vessels, you saw that increase in cardiac output. This will do the same thing. And so typically these are not used by themselves. These are going to be add-on drugs here. And so what can you see from a side effect profile? Well, just like you're dilating the vessels, you can see things like flushing, you can see dizziness associated with that from a CNS standpoint. And then for slow acetylators or people who are on larger doses, they can develop what they call this lupus-like syndrome. And so classically, we think about that butterfly-like rash to the face, but it can develop rashes elsewhere. Again, lupus can affect the entire body, but this has to do with buildup of the drug itself. So you see this more so in high dose, long-term use. Women tend to be more susceptible to this. And then if they're slow acetylators, right? And then people who are slow acetylators are also more commonly Caucasian patients. So white patients, you may be able to, again, you can't just look at a patient and tell, but you can maybe have an association there thinking, okay, well, if they're a white patient, they're coming with a butterfly-like rash, and they're on hydralazine, you should be able to link those things together in your mind, okay? So you want to be really careful here in patients, for instance, like coronary artery disease, because again, by dilating those vessels acutely, you can't see a big increase in cardiac output. That causes a big increase in oxygen demand by the heart, and that can induce more ischemia, right? Elderly patients as well, just due to the orthostatic effects. You want to be really careful there because if you cause them to fall and break their hip, that's not great from a morbidity and mortality standpoint for them. And then they also can turn the stools black, so you want to be watchful for that, or at least let them know that this can happen, so that way they don't think they're having a GI bleed all of a sudden. Okay, so what do we do in terms of blood pressure? So we basically are finding things have not changed too recently by any means in terms of the drugs that we're going to be using here. Still the same recommendations overall. And so generally, you're shooting for a goal of less than 130 over 80, and this can include patients like chronic kidney disease and diabetes and whatnot. In terms of medication selection, kind of what you go for first, some of it depends on your patient's ethnicity to some degree. So for instance, with like black patients, they tend to respond better to things like thiazide diuretics or things like calcium channel blockers, right? Something like chlorthalidone or something like amlodipine, either or, they tend to respond to a little bit better, okay? For non-black patients, so if you have Asian patients, white patients, whatnot, if they have diabetes or not, you can start off with a thiazide, you can do a calcium channel blocker, or you can do something like an ACE inhibitor. Any of those are fine there, right? They tend to work pretty equally effectively in that patient population, okay? If they have chronic kidney disease, though, they probably need to be on an angiotensin receptor blocker or an ACE inhibitor because we know these are going to be kidney protective. If they have diabetes, I'd probably also err on the side of using something like an ACE inhibitor as well because we know that's kidney protective, okay? Most patients are not going to be managed with just one drug by themselves, though, so you may need to add on something else. And so typically you bring them back after a month and you have them check their blood pressure regularly, keep a little journal. You can see that if what they're on is not currently working, then you can add on something from a different class, or you can add on, try to optimize the dose that they're on of the one drug, right? So say, for instance, you have them come in, they're on an ACE inhibitor already. What could you add on to that? Well, would I add on an ARB? Well, no, that doesn't make sense because they're doing the same thing overall. Could I add on a calcium channel blocker? Yeah, maybe. Could I add on a thiazide diuretic? Perhaps. it just depends on how the patient is going to respond to different side effects, right? Now, would I ever put a patient on a beta blocker plus non-DHP? Well, no, because they both work to diminish cardiac output. That would be more likely to see side effects, right? Notice here I didn't mention anything about loop diuretics, because loops are not really good for long-term blood pressure management. Of the diuretics we talked about, really the thiazides are the big ones there. But could you use other diuretics as well on top of a thiazide? Well, sure. Like, we know thiazides will reduce potassium levels, so maybe I'll put them on a potassium-sparing diuretic. Also, remember though, if you put them on an ACE inhibitor, that's going to increase their potassium levels. So again, watch out for the delicate interplay here between the different classes, because they all some of them play nicer with one another than other classes, and so you gotta be watchful for that. So know which ones are affecting your electrolytes, know which common side effects you're gonna see, because if you're mixing these drugs together, the drug interactions are the things you want to watch out for. Okay, hope that makes sense. Do you guys have any questions so far for this section? I'm gonna switch gears here. Looking on the sticky board, I don't see any questions. I'm gonna get started with the next one. I just uploaded that, so it's on the site. No questions at all. Okay, so I'm assuming you guys have a perfect understanding of everything, and I have done an exemplary job explaining this stuff to you. Sure. If not, you can always post them up on the sticky board or in the chat here. Do not worry about sounding silly or like I'm gonna judge you for not knowing something. You guys are here to learn, so this is the time to ask questions. So we have this class session we have next week. We're all just soaking it all in. That's perfectly fine too. That's okay. Well, this week we'll have next week, and then the test is that following week there, right? So I want to make sure I have enough time to get through everything, because I have another 83 slides it looks like to get through here. So we got to get over our antiplatelet drugs and our anticoagulants and all that good stuff here. So moving into part 3 here, we can now start talking about angina. And so it's really handy to know all the stuff we talked about for the last section, and then we can apply a lot of it to this section here, right? And again, when you're looking at medications to use for blood pressure, it's not necessarily a matter of saying what's the first line, second line drug. A lot of it has to do with what other comorbidities does the patient have that also requires the use of some of these drugs here, right? So someone who is just starting out with just pure hypertension alone, and that's their only disease state, that one, yeah, you can go with a thiazide diuretic, go with an ACE inhibitor, whatever the case may be. What you're going to see, though, is with patients who have a history of coronary artery disease, they're going to require a certain set of drugs, which many of them will treat their blood pressure. And then you can see where they're at and then add on other drugs as needed. So oftentimes the selection of drugs is based off of the other compelling indications that they have. Do they have diabetes? Do they have kidney disease? Do they have coronary artery disease? These are all going to be important features here. Okay. So anyway, so let's get into talking about ischemic heart disease. Obviously, this is anything where there is a disbalance between O2 supply and then demand. I mentioned usually the demand is outstripping the supply because we have done something to diminish flow through the coronary vessels here, right? And so with coronary heart disease, we're seeing these typically atherosclerotic narrowing of the coronary arteries, right? And so you can kind of break that down into a couple of different settings there. So there's ACS, which is acute coronary syndromes, which can include things like unstable angina, which you guys have not covered that yet. That just means anginal symptoms at rest. So they're just sitting there not doing anything. They're having chest pain because they're so having so little blood flow getting through those coronary vessels, or that can lead up to acute MI, right? Before that, we can also see things like chronic stable angina. We're going to be focusing on that as well. If you call it angina, I don't really care, but I just always call it angina, by the way. I think that's certain cases like sudden cardiac death, which is frequently caused by arrhythmias due to the ischemia that they're developing there. Because remember, when you are not supplying oxygen to those myocytes, they don't really conduct electricity all that well anymore, especially when they start to die off. They won't conduct electricity at all. So it's not uncommon to see arrhythmias as a secondary consequence to this ischemia, okay? Anyway, as we're talking about angina, again, that's just the manifestation of chest pain or the manifestations of, what we see when we are causing this myocardial ischemia, right? Usually under activity They're getting up, they're walking around, they're gardening, they outstrip demand, they outstrip supply of oxygen by the heart, and then they develop this chest pain, right? Oh, it's chest pain, can be referred to other places as well, but we'll just call it chest pain for now. And so you can see here, kind of looking at the different factors that go into O2 availability versus the O2 requirements or the demand here. We're going to see things like heart rate, contractility, wall tension, all affect how much oxygen your heart needs versus the availability. So how are we able to deliver that oxygen to the heart? Are the vessels open enough for us to get all the blood there? So you can kind of think about it as like kind of like cars and trying to deliver materials across the country in big rig trucks or something like that. Are the highways all clogged up so the trucks can't get through? They're carrying all the oxygen. Could there be an issue where the trucks don't have the trailer on the back so they can't carry oxygen, so they don't have the hemoglobin? Lots of things that can go into this, but we're mainly going to be focusing on the ability to get drugs through, or I'm sorry, get blood to the heart to actually oxygenate it, and then also looking at the demand side, so seeing what we can do to decrease how much O2 the heart really needs. Okay, so in going into myocardial oxygen demand, this is going to be a factor of both heart rate, contractility, right? So how fast it's beating, how hard it's beating, all increases oxygen demand, and then also the systolic wall tension, right? And so basically, the higher the wall tension here is, the more force is going to require to actually pump that blood out into the vasculature, and that's going to require more oxygen there, right? So it has to do with both the ventricular volume and pressure, and that means it's a function of both preload and afterload, right? So if you're not familiar with the concepts here, you can see preload. And again, if you haven't covered this stuff in another class, just let me know. I can go into more detail. But preload is basically how much initial stretch are there prior to contracting, right? So this has to do with how much blood is actually getting back to the heart from this on the venous side of things, right? So how much blood flow we're getting back, more of that means more preload, okay? On the afterload side of the things, which most of these patients are having issues with, is that they're having too much pressure the heart's trying to pump against, right? So just like any muscle in the body, the more you use it, the more it's going to become hypertrophic. It's going to become larger. It's going to also become stiffer typically, right? If you've ever seen like a bodybuilder, they're not the most flexible people on earth because their muscles are so big and they can't really move around all that well. Same thing happens with the heart, right? So again, that increased wall tension, because it's less flexible, means you're going to require more oxygen to try to pump against all that increased pressure, okay? So then looking on the demand side of things, I'm sorry, on the actual supply side of things, you can see here that as time goes on, as we develop these plaques due to things like hyperlipidemia and genetics and all of that, inflammation and whatnot, you're going to see that you're going to be narrowing this. And the smaller the diameter here, the less blood flow we're going to be able to get through here. And this is the problem, right? This is the issues we're seeing where you can have these ruptures in the plaques. This is where they can cause embolus. We're going to look at the whole clotting cascade in just a little bit. This is the thing we're either trying to prevent in the long term, or this is going to be the main problem we run into when they develop angina. So again, this can occur with any degree of stenosis, and some people you'll find they have angina even without significant stenosis, right? We'll talk about variant angina or Prinzmetal angina here in just a few moments. But basically, once you start to see significant blockage, like 50% of the left main or 75% of some of the other major vessels, that's where they really start to run into issues there. Okay. So what do we want to do for these patients? Obviously, we'd like to improve their quantity of life, help them to live for longer, and then also improve their quality of life. So if we can help to relieve their symptoms and then prevent the symptoms from occurring, that's going to be beneficial. Okay. So we're going to talk about things used to treat acute anginal symptoms, and things to treat things to prevent symptoms from occurring, right? So think about this in the same mantra like we did with asthma. We have things that treat asthma attacks acutely, and then we also have things that work on blocking asthma attacks from occurring, okay? Think about this in the same way, and so it's important to delineate between the two, because if you don't know the difference, then you don't know how to use the drugs, right, effectively. So what is our strategies here? So one, we can decrease O2 demand by the heart. So we can do that by either decreasing contractility, heart rate, or that intramyocardial wall tension, okay, which is basically decreasing preload or afterload. We can try to increase myocardial O2 demand, so try to get more blood flow going to those vessels and into the actual tissue itself. And then if we kind of in the long term, we also want to make sure that we try to stabilize those plaques to prevent an acute rupture, to prevent an acute coronary syndrome, and then to, if we can, modify any reversible risk factors, right? Because I can't make the patient any younger, can't change their genetics necessarily, at least not yet, maybe in the future, but I can certainly try to get them off the couch and moving around more, right? So those are things you want to consider there. So obviously, you know, from a non-pharmacologic standpoint, there's a lot you could do in terms of like surgery. So you can send them to the cath lab and try to, you know, try to open up those vessels some, or they could have, you know, bypass grafting and whatnot. This I'm not going to get into too much because it's outside of our purview, but I'm certainly going to be focusing on the pharmacotherapy. And as always, lifestyle modification is so important for these patients, because the thing is with these patients here is patient education is 90% of the work, right? It's easy enough to prescribe them a medication, but if they can't take it or they don't take it because they either don't see the importance or they don't, they're non-compliant for a variety of other reasons. You know, if they don't do the lifestyle modifications, you're going to have very limited efficacy here, right? So overall, you have to act more as a psychologist for these patients, more so than just a PA, in order to get them to take the meds like they're supposed to, engage in lifestyle modifications in order to keep them alive for longer, right? So that's always the tough part. So what are some things we can use to decrease heart rate, decrease contractility, and the wall tension? This is where we're going to get into our calcium channel blockers, their nitrates, and also our beta blockers are going to be useful here. Okay, things that increase coronary blood flow, we're going to look at how all these work a little bit differently, include calcium channel blockers, nitrates, and things like aspirin and clopidogrel. These are going to be our antiplatelet drugs, which we'll get into more detail here in just a little bit. So when I talk about anti-anginals, these are things that help us to improve exercise capacity, basically getting these patients to be able to do more before their chest pain symptoms kick in, right? And so that way we don't see these sort of like ST segment changes as a result of exercise, right? Just like you would see if you're doing like a stress test with these patients here, right? So these are things that help to reduce the frequency of symptoms that we're going to see. So things like beta blockers, calcium channel blockers, and we'll also get into our nitrates as well. That'll be the first new set of drugs we're talking about here. And again, how do you classify your grades of angina? Well, all has to do with when they develop symptoms, right? So again, are they having it where they have minimal activity is inducing it, or can they get around a bit before they start to develop chest pain? Notice here, though, it's always comfortable at rest until you get into unstable angina. And this is where they run into issues where they may be symptomatic at rest, and that's usually a very bad sign there. So let's look at what the different classes of drugs are going to do for us before we get into our nitrates. So for beta blockers, we just talked about those, so they should be fresh in your mind. You can see here they're going to help to reduce heart rate. They're going to reduce contractility, which is again decreasing the oxygen demand by the heart. They're going to see they help to decrease systolic blood pressure, and they help increase actual LV volume, because you're actually giving the heart more time to fill because you slow down the heart rate. So overall, you're going to see some decrease in wall tension, but the biggest thing here is decreasing contractility and heart rate. Okay. Notice they have no effect on the supply side. So they're not going to get any more oxygen going to the heart. They're just helping reduce the amount of oxygen the heart requires. And typically for these patients, this is going to be first line. And why is that? Is because we see the actually is going to be mortality benefits to this. Just like I mentioned in the last set of slides, that beta blockers are required after MI, right? It's one of those things on your checklist before you discharge a patient home after an MI. You want to make sure they're on a beta blocker, right? Because the insurance companies want to see that because they know it's good for their patient, and it keeps them from having to be readmitted and from them having to shell out an extra amount of money for that admission, right? And so this is going to be good for patients with limited exercise capacity, right? And again, we mentioned before that for younger patients, beta blockers reduce exercise capacity, but for these patients, it improves it, right? Which makes sense. If they have supraventricular arrhythmias like AFib, if they have hypertension, anxiety, heart failure, post-MI, whole lot of people who can benefit from beta blockers here, and this is why this is used first line for angina. Now, you can utilize either beta-1 selective agents, non-selective. It really doesn't matter so much. It more matters, for instance, if they have concomitant CHF, which they often will have, or it matters if they're asthmatic patients. So be able to know, if I say in a vignette, you have a 67-year-old patient and they have a history of asthma and they're coming in complaining of chest pain with activity, you want to put them on an anti-anginal which one of these would be appropriate. And you'd have to clue in this, I said asthma in there, so a beta or non-selective beta blocker would be a bad idea. Propranolol would not be a great idea. Using something like metoprolol would be, though. Okay, so those are things you want to consider when you're looking at these exam questions. It's not so much to say what's the first line drug for this disease state. That's easy to figure out. It's given the complications of patients, because they're not so cut and dry. What are the comorbidities? What other meds are they already taking? How is that going to change your selection, right? So what are contraindications? Just like we saw before, if they're hypotensive or bradycardic, do not give them a beta blocker. You're going to worsen that. If they have heart failure, you want to be really cautious with using a beta blocker. Most of the time for those patients, we have to start them in the hospital, beta blocker, because we know we can induce decompensations. We'll be really, really careful with that. And again, as I mentioned, reactive airway disease, make sure you're using a cardioselective beta blocker. Make sure you're looking at their sugars if they are diabetic patients, and tell them to look for symptom changes in terms of their peripheral vascular disease, right? Because again, one thing that you don't necessarily think about is if patients are having chest pain because their coronary vessels are clogged up, guess what? The atherosclerosis just doesn't affect the vessels of the heart. It can affect the vessels everywhere. The patients with peripheral artery disease frequently have concomitant cardiovascular disease in terms of coronary artery issues. So again, be cautious there. Just let them know, hey, look at your symptoms, see how often they're coming up. This may worsen it, so just be aware of that. Obviously, in terms of adverse reactions, we just talked about that: hypotension, bradycardia, CNS effects if you're dealing with more lipid-soluble beta blockers. All of that you want to warn patients about and just let them know, hey, just let us know if these are happening, because it may lead us to change the dose of the drug, change which drug you use specifically, all of that, okay? And again, avoid that rapid discontinuation. These patients are already telling you they're in a state where they cannot handle a lot of extra O2 demand on the heart. So if you have them on a beta blocker for months and then abruptly discontinue it, that's not going to be great, because all of a sudden that O2 demand is going to go up significantly, and that's going to cause them to probably have a heart attack. All right. Moving on, next we have our calcium channel blockers. Now, it's important to know which set of these drugs you want to use depending on kind of what's going on with the patient, right? So looking at our dihydropyridines like amlodipine, again, remember, they can actually cause an increase in heart rate, which doesn't seem like a good thing for these type of patients. We're going to see how we use these selectively. Overall contractility should have really no effect. May have a slight decrease, but roughly no effect. The big benefits here with the dihydropyridine is they reduce systolic blood pressure. So they are reducing afterload, or the pressure that the heart is having to pump against. So it doesn't have to work as hard in order to get that blood moving around, okay? Non-DHPs, on the other hand, are going to have decreases in heart rate, decreases in contractility, and then also some decreases in systolic blood pressure, okay? So again, these are going to be very different in terms of activity. You need to know the difference, because you would not use these interchangeably, okay? We'll talk about how we're going to be using them. In terms of the supply side, you can actually see some mild dilation in certain areas of fixed stenosis, and then you can have relief of vasospasm. So if you have someone who has what they call prinzmetal angina or variant angina, where they may not have a whole lot of narrowing of the vessels due to atherosclerosis, they just have to happen to have this vasospasm that can occur due to changes in temperature, emotional stress, and things like that. This can help to relax that. So we'll talk about how we use these as well in just a few moments. You can then, again, break it down and look at the specific agents here. And again, I don't care if you know how many pluses or arrows there are, but know the overall trends here. So again, with verapamil diltiazem, okay, vasodilation here, but biggest changes are contractility and heart rate, AV conduction, obviously. And then with the DHPs, mainly going to be vasodilation. Really shouldn't do a whole lot for contractility, and if anything, they bump up the heart rate. Okay, so someone who is having angina, you don't want to give them a DHP right off the bat without anything else on board, because if anything, it can actually increase O2 demand by the heart. Okay, again, that may be better, for instance, as an add-on drug. So what are the place in therapy? So for initial therapy, if they're on nothing else for angina and they can't use a beta blocker, you could use a non-DHP. So if someone has a contraindication to a beta blocker, they couldn't use it, then you can substitute it with a non-DHP, right? Now, we don't have all the evidence for non-DHPs like we do for beta blockers to help out with mortality and whatnot. But again, if they can't take it, then they can't take it. So this is where a non-DHP comes into play here, okay? If a patient's already on a beta blocker and it is not adequately controlling their symptoms and they're already kind of maxed out on their dose, then you can add on a DHP. Okay. Note here, you do not want to add on a non-DHP to a beta blocker because that causes too big of a decrease in contractility and heart rate. Okay. And then also you could use calcium channel blockers in addition to some of our long-acting nitrates, which I'll get into more details here in a few moments. Okay. So who are these going to be good for? They have a intolerance or contraindication to beta blockers. If they have vasospastic angina, like I was mentioning there, which is more of a vasospasm issue, DHP is actually going to be useful for that. If they have severe peripheral vascular disease, because it actually helps keep those vessels open and able to supply oxygen to the peripheral tissues there. If they have asthma, uncontrolled diabetes, or if they have LV dysfunction, this can also be beneficial. So for LV dysfunction, you can use DHPs only, because again, you're going to find beta blockers and non-DHPs will actually suppress LV function. DHPs will not. Okay. So again, be careful. We'll talk more about CHF next, the next section of the course, but just be aware of that. So again, how do we select our drugs here? For initial therapy, non-DHP may be used. DHPs are going to be added on to beta blockers. And in general, we like to avoid short-acting agents. They typically cause kind of too big of an acute drop in blood pressure. So something like amlodipine, more long-acting, perfectly fine to use there. All right. Contraindications, obviously for our non-DHPs, we're going to see that hypotension, heart rate, acute heart failure, all these are going to be not great for non-DHPs. For the dihydropyridine specifically, the hypotension is going to be the main contraindication there. You can use amlodipine with someone who's bradycardic. That's not really going to have any direct effects on the heart. All right, so kind of know the differences in how these drugs are acting, know how it makes sense to use them or to avoid them as the case may be, okay? Again, be careful. Almost never are you going to combine a non-DHP plus a beta blocker. At least I can't think of any good cases to use it. And then be aware of CYP3A4 interactions, either with verapamil inhibiting CYP3A4, or if you have something like amlodipine on board that is a substrate, and you add on something else that's going to inhibit that, okay? In terms of adverse reactions, we already covered these last time. So we know that things like hypotension, flushing, constipation, peripheral edema, all these can be seen here. Obviously, the vasodilatory effects are going to be more pronounced with the DHPs, obviously. So more flushing and headache you're going to see with those, for instance. Again, for monitoring, you're looking at the heart rate to see if they're actually taking it, to see if it's actually working, looking to see if they're having fewer symptoms, if they're having less often reporting chest pain there. And again, let them know about things like the constipation and the dizziness. Frequently, these elderly patients are going to have problems with constipation anyway, and so this can just worsen that. So they may need things like stool softeners and stuff we're going to talk about in the GI section later on. All right. Now, moving on to the first new set of drugs we're talking about in this section here are going to be the nitrates. So nitrates are going to help out to decrease systolic blood pressure, and they also are going to decrease LV volume. But they don't really do anything for heart rate or contractility. So these are not doing so much on the demand side. They do a little bit, but more so on the supply side. This is the really important bits here, right? So I'm even gonna highlight this and bold it because I think it's important to know. Right? They dilate the coronary arteries, they relieve vasospasm, and to some small degree they'll have some antithrombotic, antiplatelet effects, right? So what happens with our nitrates? So imagine this is a coronary vessel, some vascular smooth muscle you're dealing with. So what you're going to find is that something can come along like nitric oxide, or NO will come in here. It's not nitrous oxide, that would be laughing gas, but nitric oxide can come along here and can cause an increase in the amount of cyclic GMP that's being produced here, so cGMP. This is going to overall lead to a decrease in cytosolic calcium, and less calcium in that smooth muscle means less constriction. So you get relaxation, you get vasodilation, and overall reduced blood pressure and more blood flow coming in through those coronary vessels. Okay, that's the important bit. This is how it's working to treat anginal symptoms. Okay, how do you get rid of that cyclic GMP to prevent this from going out of control and causing too much vasodilation and hypotension? Well, there's an enzyme called phosphodiesterase 5 or PDE5, breaks down cyclic GMP. Okay, now we have drugs that actually inhibit PDE5, and this includes things like sildenafil, tadalafil, and vardenafil. These are actually drugs we use to treat erectile dysfunction by causing, we'll talk more about specifically how they work next semester, but just know this is going to be a really important interaction we're going to talk about in just a little bit. And again, if you were to combine something like sildenafil plus a nitrate, you're going to have a whole lot of cGMP being produced here because, again, these drugs are inhibiting the breakdown. and thus you're going to get way too much decrease in blood pressure. Okay, so we'll talk about that interaction, and this is actually going to be a contraindication to using nitrates along with the set of drugs here. So a couple of different ways we can use this, right? So things like beta blockers, things like calcium channel blockers, those were for prevention of symptoms. For acute treatment of symptoms, this is where the short-acting nitrates come into play here. And so these are going to help to relieve acute symptoms of myocardial ischemia, because patients are having chest pain right now. This will help to open up those vessels and get more oxygen coming in, and they will help to prevent effort-induced angina. So if they know they're going to be more active, they know they're likely to have chest pain, sometimes they can take sort of a preventative dose here. There's different varieties you can take. So for instance, here is an example of the sublingual form. They can just put underneath the tongue and allow it to dissolve, or they can have the sublingual spray here, where they'd actually just kind of spray it underneath the tongue. It doesn't matter which one they're using, as long as they're using a short acting form here, right? Now, typically they'll dose it every 5 minutes. And back in the day, we used to say, well, take 3 doses 5 minutes apart. And if your chest pain is not relieved, go ahead and call 911. Okay. That's not recommended anymore, because if they're having chest pain that is not being relieved by nitroglycerin, then they need to be seen right now, because time is tissue when you're dealing with myocardial ischemia. So now we tell them to call EMS if there's no relief after the first dose. So they take a dose, they wait 5 minutes. If the chest pain has not gotten better, then they call 911. Okay, it's important to know that. So the short-acting nitroglycerin or short-acting nitrates here, it's important to know that because it can cause that vasodilation, patients can tend to get dizzy from this one, right? And again, you don't want your patients to get orthostatic hypotension and fall over and pass out, right? Not great. Nitroglycerin itself is a very unstable drug, and so it's important to make sure we keep it in the original packaging. Notice here that it comes in a light-sensitive container, so that it prevents light from coming in, destroying the drug. And we keep it in a cool, dry place to make sure that, and again, we do not live in a cool, dry place, as it turns out. We keep it in the original container. People will try to put these like into other containers, and then they dissolve, or they will break down, and they'll be less effective. And we actually tell them to replace it after 3 to 6 months after opening, because again, the stability is not going to be such that they'll retain their efficacy. They may take it and they say, wow, it's just not working, I need to call 911, when really the drug is kind of degraded. So make sure they replace it, even if they have some left over. Make sure they're not swallowing it. Just have them place it underneath the tongue, tablet underneath the tongue, or spray, and then it will work just fine from that absorption. Right? There are some long-acting nitrates we can use as well, and these are going to be more for prevention of symptoms. So these are going to be add-on drugs you can use in addition to a beta blocker and or a calcium channel blocker if they're still having anginal symptoms, too frequent of a rate there. And so these are not recommended by themselves. They are just going to be as adjunctive therapy, so just adding it on as an additional therapy. Just like I'm an adjunct professor for you guys, I couldn't be your only professor because you'd be missing on all the other stuff, right? I'm just a helpful addition to your education. So kind of think about it like that. A couple of different drugs we have in this category. We have things like isosorbide mononitrate and then isosorbide dinitrate. Now, if you notice here with long-acting nitrates, it's important that patients are not being affected by nitrates 24 hours a day. We're going to look at why that is in just a moment here. But typically for nitrates, patients need to be sort of on a paradigm of being on for 12 hours and then off for 12 hours. The body cannot handle being on 24-hour nitrates, and I'll mention why in just a moment. But so that's why you end up seeing things like isosorbide mononitrate. It's a 12-hour dose roughly. So they take it once daily to get 12 hours roughly of activity, then it wears off, and then the body kind of resets itself. Isosorbide dinitrate, this one only lasts about 3 to 6 hours, so you end up taking it 3 times a day to get roughly 12 hours. So another forms you can also use includes transdermal nitroglycerin. So you can either use like an ointment or you can use a patch or something like that. And again, you need to do a 12 hours on, 12 hours off. The reason why we do this is because you can develop what we call tachyphylaxis, which is something I talked about last semester. Basically, if you have it on 24 hours a day, the body is going to run out of a lot of the cofactors and other things it's going to require in order to keep the drug effective. So once that happens, if I have someone who's on the paced 24 hours a day and they had, they're on for 24 hours a day and then they start having chest pain, I can give them more nitroglycerin, but it's not going to do anything, right? So that's that tachyphylaxis. Even if I increase the dose, I don't get any additional benefits. Okay. This is the classic case where this is happening here. So 12 hours on, 12 hours off for the long-acting nitrates. That way you can still keep efficacy of the short-acting ones when they need it, okay? Now, when do you schedule that 12 hours? Well, typically when they're most likely to have chest pain, right? Which is going to be during the times that they're active. So this is most likely something they'll put on during the daytime when they wake up, and then they'll be off of it at nighttime where typically they're less active. But if they're like, something that works overnights, then maybe you want to flip that over, right? So it just depends on the patient's sort of schedule there. Again, you can see either like the patch, you can just slap it on, have them take it off 12 hours later. So again, it can provide nice slow release over 12 hours, but then you take it off afterwards. And then with the ointment here, you actually dose it based off like inches. As you can see here, inches or centimeters, depending on your predilection there. But basically, you'd have this piece of wax paper here. You could actually basically put the ointment onto the page, depending on how much you need there, and then just slap it onto the patient, and then they're kind of good to go there. One thing you want to be really careful of is that because it is transdermally absorbed, if you are a healthcare provider or working with healthcare providers who are administering this, they need to wear gloves because there's been cases where people will apply it without using gloves. They get some on their skin, and then all of a sudden they're complaining about just a really bad headache. And that's because those cerebral vessels are now dilated as a result of the actions of the nitroglycerin. So good PPE is important for this. Make sure you have your gloves on. Okay. In terms of other side effects, in headache, flushing, postural hypotension. Again, all this is related to dilating all these vessels here, not just the coronary vessels, but all the vessels throughout the body. So not only that, but you can't see a reflex tachycardia, which is why we don't use these drugs by themselves, because that tachycardia is not great for O2 demand. So what we would do is add this onto something like a beta blocker. So that way they're unable to have that same reflex that is being inhibited by the beta blocker. So other things to consider here, the tachyphylaxis, as I mentioned, a lot of this is due to either depletion of cofactors or some of the compensatory mechanisms like the renin-angiotensin system. So overall, make sure they're going to have a nitrate-free interval, 12 hours, when the patient is lowest or least likely to have symptoms occur, usually during nighttime, but depends on the patient. Some contraindications here. If they have any kind of obstruction to getting blood flow out of the heart, because if you're dilating all these vessels and the heart cannot compensate for that, then you're going to have overall tissue hypoperfusion. So be careful there. And then also if they have concomitant use of a phosphodiesterase, okay? So if you combine nitroglycerin plus a phosphodiesterase inhibitor like sildenafil or Viagra, you're going to cause significant decreases in blood pressure because they're working synergistically with one another. One increases cyclic GMP production, and the other prevents breakdown of cyclic GMP. And so you can have severe hypotension. You can actually induce MI or stroke as a result of this. So imagine a not uncommon situation. You have an older gentleman. Let's say he's in his early 60s, and he is, has erectile dysfunction, history of coronary artery disease, and he is being intimate with his partner. He's being physically active. Now all of a sudden he's having chest pain, calls 911, right? They show up. The question they have to ask them is, have they taken a phosphodiesterase inhibitor? So they wouldn't say that. They say, have you taken Viagra or anything like that for erectile dysfunction? And if he says yes, then they cannot really give any more nitrates. Like, these are absolutely contraindicated together. We have other things we can do to help them out with their O2 supply, but that's going to be contraindication, okay? So EMS is trained to definitely ask for this, but you should be asking the question too when you're seeing these patients and they're showing up in the ER, for instance, okay? So again, just something to consider there, because if you don't miss that, or if you do miss that and then give them a nitrate, it can cause them to stroke out, potentially have a heart attack, even worse, because they're having such profound hypotension. So be very careful there. We'll talk more about these drugs in the urology section next semester, though. So this is a handy slide, I think, to kind of go through and look at patients' comorbidities, look at what their first-line therapy should be for preventing anginal symptoms, and then look at what alternatives you could use if that was not going to be feasible, and then which ones you might want to avoid, okay? Keep in mind, they're always going to get a short-acting nitroglycerin, either sublingual tablet or spray, as a acute treatment, right? So just like asthmatic patients are probably going to get an albuterol inhaler, they'll also get something additionally to prevent symptoms from occurring. The same thing goes with this, right? So they're always going to get a short-acting nitrate, and then they'll get something additionally to help prevent symptoms here. So if they have a history of hypertension, like a beta blocker can do both, right? They'll help to treat the hypertension and prevent anginal symptoms there. If they have prior MI, or if they have decreased LV function, so like CHF, if they have any of these, beta blockers are still good. If they have asthma, then just go with the cardioselective beta blocker. That's what CS stands for there. If they have bradycardia or AV block to begin with, then that kind of precludes you from using beta blockers and non-DHP. So then you can go ahead and start out with a dihydropyridine at that point, right? That diabetes, again, be careful with using a beta blocker because that can affect their blood sugar. So something like a non-DHP may be a useful alternative, okay? So kind of getting a good idea for the type of patient you're dealing with, what a good first-line drug would be, and know which things you'd want to avoid, okay? Also the other important thing there, because again, when you're looking at a test question, and you got 4 answer choices, one of them is probably going to be contraindicated, one of them is probably going to be the best first-line agent, and then 2 of them could be alternatives, but may not be the best to start out with. So again, those are the things you have to be able to know. That's why we ask on test questions, what is the best option? And not just what is an option, because there could be a lot of drugs that fit the bill there, but what's the best one is important to know, okay? So other things we can do to help extend life for these patients. It won't do anything for their anginal symptoms, but are still useful for, useful for preventing them from having MIs in the future. So things like ACE inhibitors are very important for these patients here because this helps to affect the left ventricular remodeling that occurs over time. And so they may be able to prevent the progression of disease for those patients there. And so if they've had a history of MI, if they've had a history of LV dysfunction, the diabetes absolutely need to be on an ACE inhibitor or ARB, right? ACE inhibitors first, they can't tolerate that, ARBs as an alternative. So really anyone with coronary artery disease, vascular disease, anything like that, they probably need to be on an ACE inhibitor. So most patients are going to require that. And again, if they're already on that plus a beta blocker, then maybe that handles their blood pressure, right? Maybe it gets their blood pressure under control there. Now, again, you want to consider, I had some other stuff on here. Oh, yeah, I do have that. So with combo therapy, again, this is where you're going to consider using combo therapy if patients are still having anginal symptoms whether on just one drug to begin with, right? So you may consider using a beta blocker plus a dihydropyridine. If they can tolerate that. Rarely do you ever want to use a non-DHP plus a beta blocker, right? That'd be a very selective sort of case there. I would leave that up to cardiologist to make that sort of decision, right? Especially if you're like working urgent care, ER, or something like that. And then if a third agent is required, they probably need some more significant workup, probably some angiography, in order to see kind of where the blockages are to see if they can fix that, right? Other drugs they probably need to be on include antiplatelet drugs, which we're going to get into coming up. And this is going to be basically to prevent platelets from causing occlusion in those vessels, right? Causing platelets from sticking together because a bit of the plaque broke off or something like that. And so these are useful for preventing acute coronary syndromes from occurring there. And so basically anyone with ischemic heart disease has to be on antiplatelet therapy to prevent secondary blockages from occurring there. And for most patients, aspirin is going to be the drug to go with. And then if that is not going to be effective, then something like clopidogrel can be a backup. Again, I'm going to go into more detail on these coming up in the next section here. So in general, for most of these patients with angina, they need to be on aspirin. If they've had a previous MI, they need to be on a beta blocker. If they have diabetes or if they have LV dysfunction, they need to be on ACE inhibitor, right? They also probably need to be on some sort of lipid lowering therapy. So they probably need to be on a high intensity statin, right? Because we mentioned patients who have a history of atherosclerotic cardiovascular disease, which angina is an equivalent of that, then they need to be on a high intensity statin, probably atorvastatin, rosuvastatin, something like that. And then in addition to all that, which again, they're already going to be on a big list of drugs, they'll need that sublingual nitroglycerin for acute relief. Okay, NTG is nitroglycerin. And then for if they're having like daily symptoms here, that's where you can consider adding on beta blockers if they're not already on one. Calcium channel blockers, long-acting nitrates, all of that. Okay, so kind of know what your initial therapy is going to be, what these patients need to be on based on their comorbidities, and maybe what you can add on from there. Because I can give you a test question and give you a question where I say, okay, a patient comes in, they're taking aspirin, they're taking lisinopril, they're taking atorvastatin, and sublingual nitroglycerin, but they're still having anginal symptoms. What would be the next thing to add on? And you look at that list and say, well, he's not on a beta blocker, and he doesn't have any contraindications, so let's put him on a beta blocker. That's the best choice. Okay, so kind of know where the patient's at in terms of what they're taking, what is being addressed by what they're taking, and then know what to kind of add on from there. Okay. So that's it for this section I'm going to cover today, I think, because I have limited time and I don't think I'll be able to finish anything productive the time that I have. I want to see if you guys have any questions, though. So we have the one more section, one more class time next week, and then the exam will be after that. So yeah, I think that'll work out pretty well. We have about, what, 50 some odd slides? A little less than that. So I think we're all set up for that. Maybe we'll have a little bit of time for review. So if you have any questions that you have, and again, I recommend asking questions in a more public forum like this, and that's why I have the sticky board, so you can ask questions anonymously, because I think that helps everybody, right? Especially in PA school, high tides raise all ships. And so if you can ask a question that you have, I guarantee you someone else probably had the same question, okay? So something to consider there. I don't see anything on the sticky board, though. So after this, I'm going to go ahead and get the prescription assignment posted up there. I apologize for that. I'll make sure I adjust it so you have 2 weeks on the nose to do that, which should be more than enough time. Think about it when you're working out there. You might be writing prescriptions, might be writing them, 5 minutes, right? So this is all practice, obviously, so I'll give you more time than that. But if you have any questions about that as well, just let me know. And I guess otherwise, if you don't have any questions, I'll see you all next time. So have a great weekend. Stay safe out there, and I will see you next week. Thank you. Thank you for joining me. Appreciate it.